Good morning, everyone, and welcome to the KHC June Community Health Forum, Achieving and Maintaining Blood Pressure Controls Through Technology. Before we get started, and as attendees filter into the platform, I'm going to take just a quick moment to run through a couple of technical items with you. After more than 2 years into a pandemic, many of you are probably very familiar with Zoom and probably experts, either willingly or unwillingly. But a few things to keep in mind during this morning's program. First, as an attendee, you will have many options to interact with hosts, speakers, and other attendees. At the end of each speaker's presentation, there will be an opportunity to ask questions if time allows. To verbally ask a speaker a question, select raise hand on the bottom toolbar. The host will be notified and then allow you to speak. If you would prefer to submit your question in writing, select Q&A on the bottom toolbar. The host will then moderate your questions to the speaker. If, for example, if time for questions runs out, speakers can revisit submitted questions after their presentation and type their answers as the program proceeds. As an attendee, you also have the option to chat with other attendees. In the chat, we will also post resources that are being referenced throughout the event. Speaking of resources, access to videos, slides, and informational material on the event is on the event page. The link is there on the screen, and it's also in the chat. And finally, as always, connect with us on social media. Follow for more information on KHC activities and share your takeaways from today's event. Now that the technical details are out of the way, let's get into the program because we have a robust lineup of great information and discussion this morning. Our agenda today includes 2 presentations on utilizing technology to diagnose and manage hypertension and the self-measured blood pressure monitoring program. Then we'll bring those concepts together in a panel to dig into how that looks in practice and finish the day with some actionable steps that your organizations can take. But before we get into the agenda, I want to introduce Lana Boisseau for some opening remarks. Lana is the Kentucky Heart Disease and Stroke Prevention Program Manager for the Kentucky Department for Public Health. This morning's program has been made possible by grant funding from the Health Department and the CDC, and we've been working with Lana and her team for several months to plan this event. Lana, I'll turn it over to you.
Thank you, Stephanie. Good morning and welcome, everyone. We are so glad you're joining us today. I really appreciate the opportunity to be here today and to be a part of this exciting forum. And we are super excited to learn from our expert panelists as they share their wealth of knowledge with us this morning. But before we dig into hearing about how they use technology to improve outcomes for patients and providers, I want to thank our friends at KHC for providing this webinar. I know they've worked so hard to ensure that the next couple of hours will be informative as well as enjoyable. So thanks again for coming today. We really appreciate it. And Stephanie, I'll turn it back over to you.
Perfect. Thank you, Lana. And again, thank you guys for your support of this programming. For our first presentation, I'd like to welcome 2 representatives from the UK Kentucky Regional Extension Center. REC provides guidance and support on technology innovation, performance improvement, and healthcare transformation for healthcare organizations across Kentucky, including large health systems, rural and critical access hospitals, and provider practices of all sizes. Michelle Hibbard, Health Innovation Advisor, and Mary Levisi, Practice Transformation Advisor, have joined us this morning to share information on utilizing technology to identify and manage hypertension. Michelle and Mary, welcome. And I think I am advancing your slides, so just tell me when to advance.
Hey, thank you, and good morning, everyone. As she said, My name's Michelle Hibbard, and so today we're excited to be talking to you about some ideas around improving hypertension using your EHR. And so you can go to the next slide there. So today, looking at our agenda, we're going to discuss the quality measures for controlled hypertension, ways to use your EHR and Health IT to identify undiagnosed hypertension, and then patients with uncontrolled hypertension, along with the best practices for identifying and monitoring reports. And then Mary Levisi will continue with tips for gaining provider engagement while using their EHR and then monitoring progress of the SMBP program. Next slide. Okay, so as we think about the best approach to identifying and beginning quality improvement efforts for patients with hypertension, it's necessary to first know how your organization is doing at this exact moment. And so the first step would include running your baseline data for patients that are diagnosed with hypertension, and then determining how many of those patients are considered in control. There are many reports that your organization may have to choose from, such as NQF reports that are found in your clinical quality measures, as well as UDS and HEDIS reports. Once you've chosen that report that you feel like is available and works well for you, we recommend defining your measurement period for the past 12 months. So a lot of times you can do like a rolling calendar, or you could also choose the previous calendar year. Once you have your baseline percentage, you can then work toward making a SMART goal. So SMART goal is one that's specific, measurable, achievable, relevant, and time-based. And so for an example, a great goal for a practice that's at 40% would be to increase the number of patients with hypertension to 50% over the next 12 months by completing the following actions. And so those actions you could determine based on some PDSAs or testing that you would like to do over that 12 months. So you now have changes to test and a goal that your team is working toward. Okay, next slide. Okay, so the one quality measure that we'll focus on is controlling high blood pressure, quality ID 236, also known as NQF 18. The majority of certified EHRs include this report as part of their clinical quality report. This report will also help you to identify several things. First, the numerator identifies patients whose most recent blood pressure is adequately controlled. That was seen during the measurement period. And you'll hear me reference to the measurement period a lot. That just means it's the dates that you are running your report for. Blood pressure readings should not be included if they are taken during an acute inpatient stay or at the ED visit, taken on the same day as a diagnostic test or a diagnostic or therapeutic procedure that requires a change in diet or a change in medication, on or one day before the day of the test or procedure, with the exception of fasting blood tests. Blood pressure readings taken on the same day that the member receives a common low intensity or preventative procedure are eligible for use. Also taken by the patient using a non-digital device, such as with a manual blood pressure cuff or a stethoscope. So just keep those in mind. And then also, if no blood pressure is recorded in the measurement period, then that patient is going to be assumed as not controlled. And one other thing is sometimes we often see that patients need to have their blood pressure taken multiple times during the same visit. And so if that's the case, whenever your report will pull this number, it's going to go off of the lowest systolic and the lowest diastolic reading on that day that was entered into the EHR. So we have that question a lot. Next slide. The denominator will let you know the number of patients that are diagnosed with hypertension. And so it is specifically looking for patients age 18 to 85 who has a diagnosis of hypertension, who's also had an encounter during the measurement period. Now, some patients will be excluded from this measure, and so some of those are listed here that are hospice, palliative care, end-stage renal disease, and long-term care. Okay, next slide. So in order for that report to know if the patient, has hypertension and if it's controlled, it's imperative that you make sure that the blood pressure vital signs are updated during each visit. I know back when EHRs first existed, it was just easy for that to be an automatic fill-in for some reason on EHR, so it would just automatically use the last one that was taken. But for this to be accurate, we really want that filled in definitely each time they're seen. And so this is an example from the Epic EHR. And so while we know EHRs are all different, this is somewhat probably the same process as what you may use within your EHR. So make sure that both that systolic and diastolic numbers are entered each time. And then the next slide. In order for you to report accurately and identify those patients with hypertension, it's also important that you go ahead and enter in on the problem list the diagnosis of hypertension at the time of the visit. And so again, this is another example showing where hypertension is entered into the problem list. So at the REC, we are firm believers in validating your report. And so we found multiple times that if you take just 25 charts, or, we always recommend 10% of your charts, just according to how much time you have, this will lead to confidently knowing that your report is accurate, and you'll also recognize workflow changes that would be helpful within your practice. To validate your report, you'll review a number of patients that are in your denominator, then go into those patient charts and verify their age, their encounter date, the blood pressure reading, and if they should be counted in the numerator and what it's showing on your report. So what we've seen in the past is spending a few hours really looking closely can help you identify that there's maybe a need to re-educate your staff on documentation of those blood pressure readings, and then also listing the diagnosis in the problem list. And then it also helps you to identify if there's any issues within your EHR. Maybe, there's something not pulling correctly that would allow you to reach out to your vendor to make them aware and get that corrected for you. So once you have identified your reporting mechanism, you want to be very consistent by running the same report monthly. If you use different reports or different time frames, you won't be able to compare your progress. So as I have my little picture here, apples really does not equal oranges. We want to make sure that is the same. The report's also very great for working patient navigation. By looking at the patients that are on your report that's included in that numerator, you can quickly identify that aren't included in the numerator. You can quickly identify who of the patients have uncontrolled hypertension. And then from that list, it really gives you an opportunity to be able to refer patients to the CARES MVP program, create CDS alerts, or make phone calls out to those patients, however you see that your navigation could help for them. Okay, and then we also have several tools that we can use as we're running reports, but we love the line charts. And so for line charts, what you're looking for is 5 data points that is going one direction or the other, which is what we call a trend. And so if you see that there's 5 data points that are improving over time, then you can see, what the changes that we have tested, that we've put into place is really working. So we need to continue to do that, or we need to spread that over our organization. Also, if on the flip side, if you see that there's 5 data points that is going down, then that's going to tell you, okay, maybe we need to look to see what's going on. Maybe the person that was trained to do something specifically has been replaced and we haven't educated the new staff member. And so it kind of just points out some things for you. Also, PDSA tracking sheets are wonderful. It's just one place that you can place all of the tests that you have, all the changes that you have tested in your organization. And so you can really document whether those worked well or if they didn't. And then, I can't stress enough, share that data throughout your organization. A lot of times we do ask staff to click all these buttons and do all these things. But whenever you share the data with them, it really makes sense. They really see, okay, this is our goal and this is what we're working toward. And so I always suggest that for sure. And the next slide, I'm going to ask Mary Lavisi to go ahead, and she's going to talk about tips for gaining provider engagement.
All righty. Thank you, Michelle. Great job. Next slide. Over the past few years, healthcare oversight has changed from thinking about value-based care versus fee-for-service. So in contrast to fee-for-service, value-based care reimbursement models compensate providers not for the quantity of the procedures performed, but rather for the quality of the care they provide, measured by patient health outcomes. And providers may think, once they leave the office, I have no control over their outcomes. So I know that's been very stressful, but one way that you can make sure that what you're doing in the office is captured, it goes right back to what Michelle said about data validation. So next slide. This is an example from an actual practice that we worked with back in March doing data validation. And as you can see, the practice screening rate, and this is broken down by providers, averaged 29.3%. We did 10% data validation on that practice. And after data validation, we found audit rates, error rates, ranging from 10 to 30% for each provider. And along with that, we also found additional audit errors that didn't necessarily impact the overall screening rate, but would impact the health outcome for the patient. So showing this type of information, a lot of times when we speak to people in quality, they say, I know our numbers are not right, but until you can actually dig into it and prove it, it's hard to take it to a leadership group and say, this is why our numbers are not correct. In this particular instance, which was rare for our audit results, this practice was actually underreporting their rate. They were actually doing the work. The results were in the record. They were just not in a place where the system could pull it for their report to capture their screening rate. So as you could see, if they were getting judged on value-based care, they are actually, closer to a 48% rate versus the 29.3%. So that is a big evidence to show your providers that data validation, data accuracy, and entering those information where it can be pulled in the EHR is critical to properly reporting the work that you're doing. Next slide. Okay, another way, and Michelle mentioned this earlier, tracking outcomes and sharing findings. PDSA forms are a great tool you can use. You do small tests of change. It can be one provider for 1 week, just in one office location. And you can test those changes out, and you can bring those results back to your leadership team or your providers to show, oftentimes the people in the front line, the nurses, the referral coordinators, the front desk people, they know small things that you can do that could maybe improve the process. And so if you do those small tests of change, and again, you have that evidence to take back with you to the leadership team, you can show what is working, what recommended change worked and what didn't. And oftentimes, negative outcomes tell us as much as positive outcomes. So don't be afraid if a PDSA form comes back and says, that didn't quite work. You can scrap the idea, or you can tweak it, try it again with a different, and then see how that worked. And be sure, once you've tested that out, to spread those positive changes throughout your organization. And as leadership knows, positive outcomes will provide sustainability for your organization. Next slide. So this is one of my favorite quotes from a CEO that we worked with in Eastern Kentucky, or she always quoted Peter Drucker: what gets measured gets managed. If you can't measure it, you can't change it. So if you don't know where you are in this particular quality measure, then you don't know what needs to be changed. If you want it, measure it. If you can't measure it, forget it. And so this particular leader, I asked for her input on what worked in her organization. This particular practice was the only practice in Kentucky in 2018 to win the Million Hearts Hypertension Control Champion. So they made amazing progress and steady progress in controlling hypertension. So here are some of the ideas she shared with us. Next slide. So some ideas for stakeholder engagement: use clinical measures and outcomes, link them to your strategic plan. It is critical that your strategic plan has your organization goals and that you link those quality measures. If you want it, like Michelle said, to make a 10-point improvement in your hypertension, put that in your strategic plan. Make it specific, measurable. By this time, we're going to make this particular gain. And with them, their goal was to gain gold, silver, and bronze HRSA QI medallion. So, they were able to achieve that. Make sure that senior leaders gain their interest with reports and feedback. Reports show the progress of your organization. Involve them in your team's work. A lot of times there might be a disconnect between the people making the higher up decisions and the day-to-day work. So be sure to keep them up to date on what's going on in the project. Have them make sure they regularly get their QI report. If you have a board of directors, give that to them. Make sure you have that show that to your leadership team. Place storyboards in visible places. Well, that's a very valuable tool that we've used in some of our most successful projects over the last few years is storyboards. It gives an idea of, this is what we're working on. This is the team that's working on it. This is what our goal is. And this is what progress we're making. Put that in a visible area so your entire team can be reminded daily what you're working toward. And be sure to distribute and post those reports and graphs so staff can view their progress monthly. It says at least quarterly. We've had some practices that report quarterly, but I would recommend that you do it monthly, because you don't want to go 3 months making a change or doing something that negatively impacts your rates, only to wait till the 4th month to fix it. You want to find out immediately if there's a problem or if something is working that you want to continue or spread. So I would recommend doing at least monthly reports, and do them if possible. I know some EHRs are not capable of this, but try to do it on the organization level, the clinic level, and the provider level if you can. And make sure that your QI staff are constantly running internal reports to check accuracy. Work constantly with your vendor to improve reports. And I know that's a tall task with some vendors. We've all been there. So just keep on them if you need to make a change to a report and you've got a ticket in and they're not responding to you or it's not done quickly. Next slide. So another thing that to keep in mind is that your report and your feedback absolutely must be accurate, concise, and meaningful. That's a snapshot of the dashboard they use. Remember, physicians are scientists. They will scrutinize the data very closely, especially if it seems to show outcomes that they are not what they thought. And CEOs or leadership are very worried about keeping the lights on and paying employees, so they will scrutinize data to the dollar. So 1 or 2 inaccurate reports will cause leadership to lose faith in the process, so validate. It is critical. Leaderships can lose track of people, so always remember to tie reports back to patient stories. Tell us stories about how a patient with hypertension was caught early and made improvement in their overall quality of life. Remind leaders about how population health monitoring also began to look as social determinants of health. That's been a big buzzword over the last few years. So is your organization able to assist with transportation or getting someone affordable supplies, or what you were able to do to help the patients overcome those barriers to improving the outcomes that you hope for? And make sure your board of directors have a monthly, make sure that if you do a report, it also includes a short paragraph with a success story, because that brings the whole project home to where the patient is the center and the most critical point of this, and we want to improve their outcomes. Next slide. Another thing Michelle mentioned, convene huddles. It makes it quick and easy for the providers to know what patients are coming in that day and what they need to be seen. If they've got uncontrolled hypertension, be sure to note that on the chart. Some people put sticky, some people put pop-up CDS alerts in the EHR. Just make sure that you do a quick huddle daily. It can be 10 minutes or less. Standing is best, in a hallway even. Just talking about what your goals are for that day. And make sure, again, that those storyboards are visible. It helps to identify what you're trying to do, what you're trying to accomplish, and you can even chart your progress on that with a graph or a bar, or almost like a charity wheel. It's like, have you reached your fundraising goal? But have you reached your hypertension goal for that project? Next slide. Some sample outreach ideas. Okay, compile a list of patient concerns. A lot of times when the patient comes in and they've only got 15 minutes with you, they have a lot of concerns they want to go over. So prioritize those concerns with the patient and address them in order. So I understand, Mrs. Jones, your blood pressure is very worrisome to you. What can we do together? What is your goal? What we can do together to improve that outcome? Use your registry to proactively contact patients for follow-up. If they haven't had a blood pressure done in the past year, those are going to count against you in the report. So make sure that you follow up with those patients that you've lost contact with, to follow up with them and get them in the office for a checkup. And then assign specific people to review your registry reports or EHR reports for patients in need of care. A lot of times a task is kind of generally assumed that everyone will do it, but if you assign a specific person, you can make sure that that gets followed up on. And when you're in the office with the patient, one of the things that we've learned is the provider's guidance is the most critical in the patient's success. So if you tell the patient, I'm referring you, you're concerned about your blood pressure, I'm referring you to this great program called self-monitoring, self-blood, SMBP, I'll cut it short, and they're going to be reaching out to you on the phone. So be sure when you get that call that you listen to that call and you follow up, or we'll follow up with an email and a face-to-face visit. So next slide. Okay, so I wanted to give you a little bit of an example before we turn it over to the next presenter on some patient outcomes when referring to self-measured blood pressure monitoring program. So next slide. So this is real data from a pilot that we did. It was a quarterly data report that was just done in March of 2022 for a set of patients that was referred to SMBP. Before they started, their average systolic blood pressure in enrollment was 160, and their average systolic BP at completion was 134. So they had a 17-point improvement in their blood pressure for attending the SMBP program on the systolic side. On the diastolic side, they started with 74, ended with 62, so they had a 10-point improvement. So this is real data, validated data, that you can give to your providers and say referring patients to SMBP can improve their outcomes. Next slide. So if there's any questions, you can put those in chat. And then I wanted to go ahead and, while we're waiting for if there are any questions that come in, the next slide talks about we are rolling that pilot that I just showed you the quarterly data over into a full Hypertension Learning Collaborative that will run July 1st to June 30th of 2023. If you are interested in being part of that collaborative and improving your hypertension rates, you would receive monthly technical assistance, attend monthly webinars and quarterly learning sessions. Patients will be educated on their options for blood pressure screening, and if they're interested, refer to SMBP at the local health department or internally if one is not in your area that provides that. You will conduct small tests of change using quality improvement methodology, and there is financial support of $1,500 quarterly. So I'll turn it back over to Stephanie, or if there's any questions, we'd be happy to handle those.
Yes, we do actually have one question in the chat, and then I know, thank you, Mary and Michelle. Will also be joining us back for the panel, so we'll get more and probably some more questions at that time as well. Bev asked, where do we find PDSA tracking sheets?
We would be happy to. We will. We have a template form that we use, and we also use a PDSA tracking kind of results in our quarterly or monthly reports to leadership. So we can provide you with both of those options or both of those tools.
Okay. Well, thank you, Mary. And we'll see you. We'll see you back here in just a couple of minutes.
Absolutely. Thank you.
Thank you, Mary and Michelle. Whoops, excuse me. Mary and Michelle talked about the SMBP, and I noticed you tripped a little bit on that word, on that spelling out of that acronym, as I did as well earlier this morning, because it is a mouthful, which is why we refer to self-measured blood pressure monitoring program generally as SMBP. So we're going to get a little bit more into that. They talked about that being one of the most important strategies to improve outcomes for patients with hypertension. So our next speaker is Natalie Littlefield, and Natalie is joining us to give a brief overview of the CARE SMBP program. Natalie is the CARE SMBP program director for the Kentucky Heart Disease and Stroke Prevention Program. Natalie, I'll turn it over to you.
All right, awesome. Thanks, Stephanie, and good morning, everybody. So I am going to be talking to you today about our CARE SMBP program that we have through the Kentucky Department for Public Health. So next slide, please, Stephanie. All right, so a little bit about what SMBP is in general. So self-measured blood pressure monitoring, that's the last time I'll say that full phrase just for all of your all's sake. It's defined as the regular measurement of blood pressure by a patient outside of the clinical setting. So that means that the patient is taking their blood pressure at home, ideally, or maybe using a publicly available cuff, say at a Walgreens or site like that has a publicly available monitor. So when someone is enrolled in SMBP, at least initially, the gold standard for doing evidence-based SMBP is to take a reading twice in the morning and twice in the evening for 7 days. And ideally, those readings should be 1 minute apart. So a person sits down at the table, takes one reading, waits a minute, takes another reading, and then if those two readings are vastly different, they would take a third to make sure that they're getting the most accurate measurement if the first two aren't very similar. Next slide, please. So what is the evidence base behind SMBP? So studies have shown there's 4 major evidence-based components of SMBP programs. The first one is that the patient has a blood pressure monitor. So we know for a lot of our patient population that we'll be working with, they don't have a blood pressure monitor, maybe because they're not able to afford it, or it's just not something that they've ever considered purchasing before. But it's very important that they have a blood pressure monitor that they have regular daily access to. The second component is that the patient can correctly use the blood pressure monitor. So not enough to just give them that and send it on their merry way, that they actually understand how to correctly use it. The next component is that patients document their blood pressure readings. So sit down, take the measurement, and write it down somewhere that they can keep a log and have that readily available, so that for the fourth step of evidence-based component, they can share that blood pressure log back with their provider. That's the whole goal of evidence-based SMBP, is to get the provider more accurate in the moment readings during a patient's day-to-day life. So we know that a lot of patients, when they go into a doctor's office, may have white coat hypertension, where they just are a little bit worked up or nervous during their appointment. So that blood pressure reading may not be as accurate necessarily as the one that they're taking in their home when they're comfortable in their own environment. So the ability for the patient to be able to give those logs to the provider just helps the provider to better inform the care that the patient receives. Next slide, please. So a little bit about the first part of the acronym CARE SMBP. So CARE is an acronym that stands for Cardiovascular Assessment, Risk Reduction, and Education. And so that program has been around for more than 10 years, and it was initially started by the Kentucky Heart Disease and Stroke Prevention Task Force many years ago. And what it is, it's a blood pressure awareness program for men and women in Kentucky ages 18 or older. And the program really emphasizes patients understanding their blood pressure more than just a number. So we know for a lot of patients, it's overwhelming when you go to the doctor and all these numbers are being rattled off and you're not really sure how those numbers really translate to your health. So the CARE Collaborative program uses a color zone scheme to help patients identify their blood pressure. So using red, yellow, and green blood pressure zones, like a stoplight model, just helps for patients to really be able to understand and associate, okay, if my reading is greater than 140/90, I'm hypertensive, I'm in the red zone. That means that I have a greater risk for heart disease and stroke. And then we go into a little bit of education on things that they can do to improve their blood pressure, get it down to that green zone where they have less of a risk for heart disease and stroke. And the whole goal of the program is that the patient is able to hear the numbers, see their blood pressure numbers, and say definitively, I'm in this color zone. Because we know that the color zone is shown to have a greater impact on the patient's ability to kind of own that number and know that they can do things to make a difference. So next slide, please. So the CARE SMBP program that we have, it combines the CARE Collaborative, so that education and that color zone blood pressure identification with traditional SMBP. So the program is designed to be 3 educational encounters in length. During the first educational session, the patient receives a monitor, is trained on how to use it, gets some baseline knowledge, education around blood pressure in general, and they're taught different techniques that they can use for self-monitoring. So making sure that they're properly positioned, that they haven't had any caffeine in the past 30 minutes, that they haven't exercised in the past 30 minutes, all those different prompts that can help to give the most accurate blood pressure reading. And then during that first educational encounter, they also learn about the different impacts of their behavior that can influence their blood pressure. So you'll see on the bullet below, they receive different options for things that they can select as modifiable lifestyle behaviors. So we ideally want them to select one modifiable lifestyle behavior at the beginning, so that they have a goal that they can really build confidence around and something that they're interested in and feel like they can really make a change in. So during that first session, they pick from that list and then they set up their second encounter. During their second encounter, they go over that educational topic that they selected, troubleshoot if they're having any issues with their monitor, really conversational based around how they're doing with self-measured blood pressure monitoring. And then in the third educational encounter, they kind of wrap up what we would consider our program. So we intentionally made it short in length so that people didn't feel overwhelmed. When people are asked to enroll in a program that's, a month, 6 months, a year in length, it can be kind of overwhelming. So evidence-based SMBP supports that it can be about a month in length, at least initially, to get the most accurate blood pressure, paint the most accurate picture of what a patient's blood pressure is. It's better to have shorter, concise information than information over the course of 6 months or so. So during that last session, that's kind of where we leave it to the patient if they're interested in continuing self-monitoring and making changes around the lifestyle behavior that they initially chose. That's what you can continue on with. If they decide that they maybe want to go a different route, so maybe initially they selected nutrition as being a big focus area for them, but they decide they want to start making some progress towards tobacco cessation, then you can kind of gear the conversation and the rest of your visits with them around that. So it's really designed to be guided by the participant and what they're most interested in. And the reason that we chose these 7 educational topics, at least at the beginning for our topic library, is because those are the American Heart Association's Life Simple 7 things that an individual can do to improve their blood pressure. So we're continually building out our topic library, but those are the 7 that we have initially built into our program. And we've been really, really happy with the pilot site results that we've gotten over the past few years. So as Mary showed in a previous slide, some of the measurements and outcomes that they've seen through some of their pilot programs. We've done a couple other pilot programs, and they've seen an average reduction of systolic blood pressure by 12 millimeters of mercury, and then diastolic 6 millimeters of mercury reduction. And next slide, please, Stephanie. The reason that that's so impactful, as you guys can see on this slide, even reducing systolic blood pressure by 5 millimeters of mercury has a big impact in stroke and heart disease improvement, lessening your risk for those events to happen. So, on average 12 reduction, that's 28%, greater than 28% reduction in your risk for a stroke, and greater than 18% in your risk for coronary heart disease. So those little impacts on blood pressure make a big, big difference. And that's something that we're really grateful for, to see that our program has resulted in those changes. So that is a little bit about the CARE SMBP program, and I'll pause there and see if there's any questions.
I do not see any questions in the chat, Natalie, but if attendees do have, after contemplating on some of Natalie's comments, have any questions, go ahead and continue to put those in the Q&A box or in the chat, and Natalie can answer those electronically.
Okay, and I'm also going to put a 1-page infographic that kind of outlines what I just talked about in my presentation. I'll put that in the chat so everyone has that as well.
Fantastic. And I think our KHC Natalie is going to put the email address for Natalie Littlefield that you see on the screen in the chat as well. Thank you so much, Natalie, for sharing the overview of the program with us.
Thank you.
At this point, I'm going to ask all of our panelists to turn on their video as we spend the next 55 minutes digging into the themes of the first 2 presentations. In those first 2 presentations, we learned about the role of measurement and technology in identifying hypertension and how to establish proactive identification and monitoring. We learned from Natalie about the CARE self-monitored blood pressure monitoring program and how it can be utilized to improve outcomes. For this panel, we're bringing it all together to examine the processes and challenges and successes of adoption of EHR and HIT to improve provider outcomes and patient health outcomes in both the identification of individuals with hypertension and the management of adults with diagnosed hypertension, particularly within the SMBP program. So we're really just, we learned a lot of technical things this morning, and we're kind of looking at that in practice for this panel. I am Stephanie Klauser, and I will be monitoring this morning's panel discussion. I've had the opportunity to speak with our panelists a couple of weeks ago, and I'm excited for the robust conversation we're sure to have. I have a list of moderated questions, and as we go through the panel, I encourage you, the attendees, to utilize the Q&A box once more and raising of hands to submit your questions for the panel as well, because we have left time for attendee questions. So panelists, as I introduce you, I think almost all of you have prepared a couple of slides and opening remarks based on a couple of prompts that we talked about in advance of the event. So as I turn over the floor to each of you, please explain how your organization interacts with patients and where you are in your journey to incorporate technology into the identification and management of hypertension, referral to SMBP, and or management of the SMBP program. Basically, what does that look like for your respective organizations? Again, please keep your responses to less than 5 minutes so we can have plenty of time for our discussion. Mary and Michelle, I'll start with you since we've heard from you already this morning. This morning, we heard from your organization, particularly about the technical side of identifying, establishing, and monitoring of hypertension. Is there anything you want to briefly note that is relevant to this panel discussion introduction that you might not have discussed in your presentation?
Just that we're working on several projects with the Department of Public Health at the Kentucky Department of Public Health. The REC was established 11 years ago for the Office of National Coordinator for Health IT to try to improve the use and the interoperability of health IT. So we've been around for a while. We're doing everything from HIPAA security risk analysis, project management, helping practices get patient-centered medical home credit, patient-centered specialty practice, value-based payment program. But one of the great loves that Michelle and I have are working with the Kentucky Department of Public Health on chronic disease grants. And several of our grants, we work on the pilot that I mentioned earlier, but we also work on a diabetes learning collaborative that has one of their core measures as hypertension control. Because as we know, many patients that have chronic disease have multiple chronic diseases. So you have to take into consideration how one may impact another. So we're very fortunate to work with them on multiple chronic disease grants. And we're very happy to be here. And we've got, on the next slide, we've got a team of health IT advisors across the state that works with practices on all of the different programs I discussed. So we're just really happy to be here and very humbled with all the practices that we get to work with to improve their clinical quality measures. Thank you.
All right, thank you, Mary. Next, I'm going to turn to our representatives from Family Health Centers to introduce their organization. Dr. Cassie Hobbs is a clinical pharmacist, and Kristen Monroe-Layton is the Director of Health Education for FHC. Oh, Kristen, you are muted. If you could unmute yourself.
All right. Thank you. Sorry. Just a brief introduction to Family Health Centers. We are a large system of federally qualified health centers in Louisville, Kentucky. We have about 40,000 patients a year. And like most FQHCs, we have primary medical care, but then lots of additional services because our patients are in need of lots of assistance. And then I represent the health education programming, and Cassie, Dr. Hobbs is with Sullivan University, a partnership we're really lucky to have to be able to offer clinical pharmacy programming on site. Next slide. So of those 40,000 patients, you can see that for adult patients, hypertension is our most commonly diagnosed condition, with about 8,000 patients a year being seen who have hypertension. Next slide. So to address, to try to improve our hypertension control rates, which are right now about 60% of those patients have an in control blood pressure and 40% do not at their medical visit. These are our UDS numbers. We have 2 separate programs to help patients. Our broad scope program we call BP at Home. This is a HRSA grant that about 500 FQHCs around the country got, including 7 in Kentucky last year. We are tasked with providing 4,365 of our patients with hypertension, could be controlled or uncontrolled, with home BP monitors, and then using those readings in patient treatment plans. In that program, we try our best to use SMBP and some of the materials from the CARE Collaborative. The scope, the number of patients we have to reach with that program makes it challenging, and the depth of the patient education that the patients get varies greatly, but we do provide information about hypertension, about color zones, about how to use the cuff, why sharing your readings with your provider can help, and lifestyle changes that you can make. For health information technology that's included in that program, we are using our lab EHR program to track provider referrals and patient enrollment. We are working with a vendor that has an app that patients put on their phone that reminds them to take their blood pressure daily and allows them to transmit those home readings to us. We have a dashboard where we can get alerts for patients who are sending in high readings. We can send messages to patients, and then we use our regular EHR to send those home logs to the provider to communicate with the provider about follow-up steps to help the patient schedule a follow-up appointment. So all of those things are being utilized as part of that program, and Dr. Hobbs is going to talk about our more intensive blood pressure program for patients. Next slide.
All right, so BP at Home Plus is still SMBP program, but we have an interdisciplinary team of a nurse practitioner, pharmacist, health educators. In the past, we've utilized community health workers. We don't currently have one employed for the program right now, but that is something that we plan to do again. And SMBP is very important for this program as well, but the patients do get to meet individually with the interprofessional team to focus on hypertension and heart disease risk reduction. So other things of getting diabetes under control, their lipid management, the lifestyle changes that can also lessen the risk of heart disease. So where we use the EHR, the electronic health information technology, is very similar in this program as it is for the BP at Home. So patients are being referred within the EHR to the program by their providers. We do utilize televisits for this program, not for all of our patients, but some of them. And so we can have video appointments for patients that may not be able to physically come into the office. For our data entry, we're utilizing a separate program, REDCap. We've, as was spoken about earlier this morning, if you can't retrieve data effectively, then it's difficult to make decisions based upon that and making sure you're getting the correct information. So we've actually gone outside of our EHR for this specific program to make sure that we're getting the data that we actually need and we're able to get it efficiently. And then another thing that we've recently started is utilizing the patients that are in the BP at Home program and those that we're constantly getting alerts or haven't been able to get their blood pressure down, even with a follow-up provider visit. We're being able to utilize that health information that's being submitted through the app or scanned in, even brought in with the paper logs to refer patients from the BP at Home to the BP at Home Plus program. So it's another recruitment source, being able to use that health information technology and what the patients are entering on the app.
Okay, thank you, Cassie, and thank you, Kristen. Next up, Allison Manning is a family nurse practitioner for Juniper Health at their Breathitt County practice location. In her role, she manages chronic conditions for adult patients with hypertension, hyperlipidemia, diabetes, and others. Allison, please introduce yourself with some comments on where your practice is in its journey to incorporate technology into identification, management, and referral to SMBP.
All right. Well, my name is Allison Manning. I work at Juniper Health in Breathitt County. It's in Eastern Kentucky. We have several clinics: Wolfe County, Breathitt County, Lee County, Morgan County, and Elliott County. And our patients are not able to really use the technology so much, but I'm kind of coming from a totally different standpoint. I do the referrals for the patients. They're my chronic patients. I've been here 8 years. And I refer them. At the beginning, what was made was our care coordinators came up with a list of the patients with uncontrolled blood pressure. We were provided with the list to look over it and see what patients would be best to refer. And of course, if they're your patients, you know which ones are appropriate. Then we brought the patients in, told them about it, and then we referred to the health department for home. But it has been very beneficial because we've had patients who've come in with like white coat syndrome. And yet at home, they'd say their blood pressure is fine, but they'd be using a cuff from like their great grandma from 25 years ago and it not be accurate. And I didn't really feel comfortable, you know what I mean, adjusting their blood pressure here in the clinic and not knowing exactly what it was at home. But our patients have really limited resources too, as far as transportation, as far as even to be able to afford a blood pressure cuff for some. So it's just been amazing to see the results and to see them take a hold of their health and understand it better.
Thank you, Allison. Our final panelist is Jenny Moorhead, Executive Director of Wellness for HealthWorks Medical. Her perspective is a little bit different than some of our other panelists, as HealthWorks provides comprehensive healthcare to corporate clients and their families. Jenny, why don't you tell us a little more about what your organization does and how it incorporates some of the themes we've discussed today? Jenny, you're on mute.
But see, and that was my biggest fear. So there you go. It's over.
Oh, now it's behind you.
Yeah, biggest Zoom fear. So one of the things that we try to do with HealthWorks is with the SMBP program, we're have different facets. So we are privately owned, first off, and we have 4 arms that we handle wellness, and particularly with the SMBP program. So we have an occupational medicine division. We have a primary care division, which is like traditional for work families. We have a corporate health and wellness program, which is where I sit all the time. And then we do have a traditional family practice that is just like a traditional doctor's office. The types of employers that we handle, because employers ask us to take care of their employees on their sites, and they come see us for direct primary care. Our primary focus when we started out 12 years ago was the river industry. Paducah is a large hub, one of the national hubs for the river industry. So we have some of the largest companies that we manage there. We have national trucking services, chemical and industry plants in the Calvert City area. We're also the medical director. I'm not, but our owner, Dr. Trumbo, is the medical director for the Department of Energy here in Paducah. Lots and lots of construction firms. That's my background in occupational safety and health. So a lot of them came on board. Cities and municipalities, first responder services, fire and law enforcement. And Natalie brought up white coat syndrome, and they have it a lot. And so going out to them and their locations has been helpful. And then lots of nonprofits. We have some churches and nonprofit organizations that we manage and help. And it's really been nice to have such a cross section of who we take care of. The thing about those particular industries is we don't, in HealthWorks, we don't take health insurance. The companies pay specifically one fee per month per person, and no matter what they need, no matter how many times they need to be seen virtually, in person, at their sites, with our wellness team and our nurse practitioners, it's all encompassing. And so we have a perspective where there's not a barrier financially for them. Then our traditional family practice is health insurance utilized just like any other practice, and they both funnel into our SMBP. And next slide. How we utilize technology. I noticed that one of the questions was who uses Bluetooth? And I will tell you that we use Bluetooth and paper logs. Probably 75% of who we deal with is on Bluetooth blood pressure cuffs. But all of our medical arms funnel our patients into us. All of our providers, we have a prescription pad that was developed. And it was one that was developed for us specifically, where our providers take that and they write on there what they want the goal to be for the employee or the patient, no matter which side they come from, how many times they want them to test a day, and then on what they want us to do with them, how they want them to be educated. The Bluetooth blood pressure cuffs come from my wellness division. They are provided to us. And they're at no cost to the employees. We don't charge them through health insurance or back to the employers even. If they have a smart device, which is what most of the river industry and the trucking industry and all of our EMS fire personnel have, they can take their blood pressure, and we encourage them to do so in their most comfortable setting. And so that could be, and for us, we have found that those that are especially in those high stress environments, their most comfortable spot is in their cruiser, in their fire truck. Believe it or not, and they don't have the white coat syndrome. We check those every day, and then our providers tell us what we're looking for. Those that do not want to use the app, for example, I have a whole section in one of my municipalities that the average age of the group is 55 and above. It just depends. I have some that still have flip phones, they're hanging on to them forever, but they can take a picture. So we give them paper logs, they fill them out, and I have them text them to us. All of our phones are HIPAA compliant. We have a 2-factor authentication when they come back to us so that we can get those. Patient reports, the provider tells me per employee what they want. I want a weekly report, a bi-weekly report, whatever they want. And that's how we do it through the app that the Bluetooth blood pressure cuffs are connected to. So that they know the high, the low, and the average, and also what time they did their testing. Because a lot of times what happens is our providers will say, I need to adjust medicine, I need to change when they take it, or dear Jenny, I need for you to bring them in for an appointment. And on the regular side, the patient that comes to see our family practice, our wellness division, our EMRs are the same, so that we don't have 2 EMRs. We can call that patient, make an appointment for them. On the private practice side that is based only for employers, direct primary care, we just call over there and tell them, hey, I need for you to be in the office in 10 minutes, or I'm going to put you on a virtual call, because we only service those employers and their families. We communicate several ways. We make monthly reports and face-to-face meetings with all of our patients, at least monthly. I will tell you that the only ones that probably aren't more frequently than that are the ones that are in the trucking industry. Trying to get them monthly sometimes is a challenge. A lot of face-to-face care virtually on the river, phone calls, text with permission, obviously from the patients. But our team, we being private, we have the ability to do a lot of things. But that's what we do. So I'm excited about it.
Thank you, Jenny. And thanks for everyone for introducing themselves and their respective organizations. And at this time, I ask if there are any panelists who've turned off their cameras while allowing the others to speak. If you could ever, if all our panelists could turn them on. I do have a list of questions I'd like to start getting into. Some of these I might direct first to specific organizations, and some I'll open up to the field. Feel free to jump in, of course, if you have something to add to the discussion or build off a comment you've heard another panelist make. And again, attendees, I encourage you to utilize the Q&A box for any additional questions you might have. And speaking of that, I'm actually going to start immediately off the bat going out of order because we had a comment or a question in the chat about Bluetooth technology in SNBP. I know Allison in her comments talked a little bit about this, as referenced this in social determinants of health. I think Mary and Michelle both mentioned social determinants of health. So let's actually just start there. Recognizing issues like transportation, food insecurity, and other social determinants of health, are these being addressed through the processes, the workflows that you all have, and in the SMBP education. Jenny, I know you and I had a conversation, and you brought it up in your opening comments about some of your clients who might not have the ability, knowledge, or willingness to use an app. Could you talk maybe a little bit more about some of the social determinant of health issues that you recognize in your organization?
We do, and because we're on two different sides of the fence, on the private practice side, one of the things that we're excited about is the community health worker program through the Purchase Area Health District. They have asked if we would be interested in utilizing those, and we have signed that we would be willing to work with them when that gets started. And one of the things that we do on the private side or the direct primary care side, where employers are asking us to provide care, we hired an interpreter because one of our largest manufacturing firms is in Bayfield, Kentucky, and probably 2/3 of their population is Hispanic. And I do not speak Spanish. And so we hired a young lady, and that's her whole job in life, is to go out and make sure that communication skills are there. Of course, Mayfield was leveled during a tornado, which brought out a lot of the social determinants of health. And so we have spent a lot of time there making sure that food is available and our patients are taken care of. But we also have a lot of people in the river industry that they may come out of the jail system where they've served their time and they are now being hired, and some of them don't even have a house to live in. So one of the things that some of the companies do is they provide basically a hotel vessel because they go out for 28 days and come back in. Part of our wellness team with our patients is to make sure that if they have issues, whether it's how to balance a checkbook, how to make sure that they cook properly, those types of things, we take care of those as well. So it's a little different on both sides, but we try our best to take care of them and get to know them as best we can, because we do have a lot of people that while they're employed, they're on the lower scale of income. And sometimes they're at the poverty level where they still need help, even though they have a full-time job.
Yeah, and Allison, you mentioned in your organization some of those challenges. Could you talk a little bit about that?
Yeah, ours is a lot, transportation, also limited income, and just places to get it. A lot of the insurances here, most of our patients we have commercial, of course, but most are Medicaid, and insurance will not cover a automatic cuff, and obviously they don't really know. I mean, it's difficult to get a manual cuff at home for a patient anyway. So the biggest thing that I have seen is the opportunity for these patients to actually get the cuff and have somebody come to their house because they are not having to go somewhere else. That has helped the limited resources. And I'm so sorry with that first question, the EHR, I was nervous and everything, but we do utilize it. It's just a lot of our stuff is done on paper, and then our front office, they scan it, and us as the providers, we get it and we are able to review it. But I'm sorry, my mind was,
No worries. And I know, I think Natalie Littlefield kind of called you out, Kristen, for this particular question as well. On statistical comparisons of Bluetooth versus SMBP.
The Bluetooth, using getting the readings electronically and how that works with SMBP.
Mm-hmm. I believe so.
I think it can be really helpful because you can get the immediate data from the patient. We have a rubric that we have worked through with our chief medical officer of how we respond to the electronic readings as they come in. So that, if a patient has 2 readings in a certain, range within a week, then we need to call the patient, make sure that they have an appointment within 2 weeks or within a month, depending on the number. So that immediate feedback from the patient is really good. I would say we have challenges with the app, just in how it's built. The one that we chose only allows the patient to send in 1 reading a day. And so, they can't really do the full SMBP of doing 2 readings a day that's recommended initially. So that's just a limitation of the app. But it was a compromise that we made in choosing that one because otherwise it's easy to use and has some other benefits. And then the other challenge, of course, is the same that Jenny has is, patients just not having the correct device or correct the interest or ability to use the app. And so we do have patients using paper logs too.
And data is an integral part of quality healthcare. As the director of data management, of course, one of my first questions is going to be about data. Michelle Mary talked specifically about the importance of the NQF-18 measure, which measures controlled hypertension. But what other data should be routinely collected and used for hypertension management? I'll open this question up to the floor for any of our providers to weigh in on what's been helpful to you.
I can speak on this, I guess, a little quickly, but although we call our program the Interprofessional One BP at Home Plus, I more think of it as a cardiovascular risk reduction clinic, because we are not only focusing on the home blood pressure management and really getting the patients to be engaged in that part of the process, but we are also closely looking at lipid panels, every visit, looking at their ASCVD risk score, making sure that statin therapy is appropriate, if whether it's needed or not needed. And then as well as is aspirin therapy or whatever other options might be the best for this patient, and making sure that we're looking at all of those components. And then I mentioned earlier as well, blood sugar management. So really trying to look across the board at all pieces that can lead to cardiovascular disease, and what can we be doing to help the patient mitigate the risk.
Any other thoughts on the panel?
One additional measure that several practices may be using if they deal with a lot of Medicare patients is a MIPS measure, MIPS 317. It's preventative care and screening for high blood pressure and follow-up documented. So that's another measure if you're reporting on Medicare that you can utilize. And again, another thing, I know it's not an NQF or that kind of a report, but tracking the PDSAs and the success stories, I think, is a valuable tool as well.
I'm going to direct this next question first to Family Health Centers, because you guys sent me some supplemental slides that looking at, I think you have a related slide that could be helpful. And while I pull that up, let's see, when a patient is identified for referral to SMBP, what is that referral process like for your organization, and who is delivering the patient education and training? And I think this, I'm going to resume the share. I think this might be helpful to have up on the page for our attendees.
Sure. So this is some material that we shared with our providers about how to refer patients to the BP at Home program. Remember, this is our program where we have to serve 4,000 patients. And so we are trying to reach patients at the time they are coming in for a regularly scheduled medical visit, rather than doing outreach or advertising the program directly to patients. We know we have 8,000 patients that come in a year who have high blood pressure, so we are asking the providers to talk with the patient about the program. Then once the provider gets the patient interested and they agree, we have some check boxes in our EHR, and they actually order the cuff as a lab. This was just done for logistical ease because we have 7 locations, but we have limited health education staff. So providers are able to send the patient to the lab with a lab order to pick up their cuff and receive some of the education. And then the patient follows up with the PCP. So for this particular program, all of the education, the referral, it's all driven by follow-up with the PCP, that the PCP has those home readings at the follow-up visit. For the BP at Home Plus program, the enrollment can come directly from the provider to us. We can reach out to the patient and help them schedule, and then we have them meet with us individually to do a lot more intensive education as Cassie was describing.
And Allison, you mentioned your role in referral as well. Could you talk about what that looks like for your practice?
Yeah, it's kind of the same way. We identify the patients at their chronic follow-up. Our patients with the chronic conditions usually follow up every 3 months or as needed, of course. Once I kind of give the patient education, make them feel comfortable about it, then I initiate a referral to my referral clerk. Just have to send a message through EHR. I put the referral into our Breathitt County Health Department, and then she contacts the health department and arranges it. Then the health department themselves contact the patient. They set up a date that they can come out. They fit the cuff and all that with the patient. Then the patient will come in. If it's uncontrolled, they'll come in within a month. If they're in their green zone for the most part, then, I'm going to see them every 3 months. They also have the option to do telehealth in between if they have any questions at all also. So.
And Jenny, how does that referral look like? I know you're not doing the referral, you're getting the referral. And I think you get them in a couple different ways, directly from the providers as well as reaching out to employers. Can you talk about that?
We actually get referrals in 2 ways. So our wellness team, part of the services that we provide to the employers that we take care of is we go out quarterly and do classes based on the biometrics that we collect once a year. We have a medical screening where we take care of, we do venipuncture, we do different blood work that we can take back to our providers for the basis for their first physicals. And we also do blood pressures and the basic biometrics that you collect for everybody. And at that time, all of our wellness staff, if they have somebody that has high blood pressure, they immediately make an appointment for that person right then so that we can get them into our clinic to be able to be seen as soon as possible. We do have providers that go out on site on a regularly scheduled basis that we can also get them there if maybe the person does not have transportation to get to one of our clinics or virtually, depending on what they want. But then the other way we get referrals is through our family practice that they literally have a prescription pad that they fill it out for us. And it has all the information on it, and it goes to our checkout clerk, and she puts it into our EHR that goes to our wellness division so that we can reach out to that patient and get an appointment with them that's convenient to take care of them. Sometimes we have to go to their work site to put a blood pressure cuff on them, but that's what the wellness team does is they're out on site most of the time.
And I'll open this next question up to the panel and just happen. I'm sure all of you probably have thoughts on this, but from your various activities in tracking and identification, referral, management of hypertension, what kind of impact have you seen from implementing these processes in workflows? And what have you seen in the data? And I'll ask a little bit about any success stories in a moment, but on a broader level, what are you seeing in your data? Feel free to hop in. I know REC shared a little bit of their data.
Yeah, I could just add one more thing that we're seeing that the providers are better able to close the referral loop with the patients, with the information coming back to the provider from the health department on SMPP, that they were able to then follow up with the patient when the patient made the next office visit. So just a better way to close that referral loop. Oftentimes you refer someone out and you never know what happened to them at that next thing. But with this SMBP program, you get that feedback immediately.
I was just going to share for our 2 programs, the Blood Pressure at Home Plus program, we get a lot of support with data from Juana's team and consistently have really good control numbers for patients who are participating. Over 70%, and really all the patients start out as uncontrolled blood pressure in that program. For the Blood Pressure at Home program, it's much less intensive, and so we weren't actually sure what the impact might be. Maybe we had compromised a little too much in our effort just to get the cuffs out the door that HRSA wants us to get out. But we did some preliminary data from the first 6 months and found that overall about 60% of our patients with hypertension are in control, but for patients receiving cuffs through that program, only 40% were in control at the provider visit where they received the cuff. So, that was eye-opening, but it also told us that our providers are really trying to get the cuffs to the patients who need them the most. And for the patients who had a follow-up visit with their provider during the time that we were looking at, it got up to 50% were in control at their follow-up visit with their provider. So we're not where we want to be yet, but we do see the impact of providing the cuff, of having the patient take their blood pressure readings at home, starting to have an impact with that program.
And I think piggybacking off Kristen is empowering your providers. Now they have a tool that they have somebody else who can support them in supporting their patients. And that's a really big help to us because it gives us one more tool in our ability to go out to employers or have them come in to be taken care of. And that helps a lot. And then the whole care loop, like Mary mentioned, the care loop and that care gap all of a sudden comes full circle because they see reports on the basis that they've requested as a provider, so they can say, yes, what I'm doing is working, or what is the disconnect and how can I make that better?
Any other thoughts before we move on? Okay. I think one of you mentioned follow-ups with providers and what you're seeing there. Patient education and engagement is crucial, particularly in this SMBP program. So in an ideal world, how do the patient and the provider partner with each other through SMBP to improve outcomes? And have you seen that happening since you've implemented that referral? And this is directed at anyone.
As far as you have to make them be comfortable with it, because if they think that somebody, like as soon as I say health department or home health, I mean, it's basically that's how they identify. If they think somebody's going to be coming to their house or calling them all the time, they're going to be like, no, So you really have to educate them and let them know that this is what it's going to be. This is going to help. This is going to help decrease your risk of, cardiovascular disease, stroke, kidney failure, and just really educate and help them be comfortable. And if you have that relationship with the patient, it goes well. But if you hit somebody off with it right off the bat and you just met them, they're not as comfortable with it. But if you really educate them and you have that rapport, it goes well. It really does.
It sounds like setting expectations for the program is very important.
Yes. Yep. Absolutely.
And what have any others on the panel seen as well?
I don't know that this directly answers your question, but it kind of goes to Allison's comment about setting the expectation and developing the relationships. We kind of see a split in patients where some, because it's a pharmacist ran service, it's not their typical primary care provider, that they're used to seeing. But we get patients who maybe they've been suggested to start a medication and they are very against that. And so being able to take the time to sit down with them to talk about the pathophysiology of what's going on with blood pressure, talking about other lifestyle management changes and supporting them in those efforts does help some individuals to feel heard, and not, we're able to have a little bit more time just to focus on blood pressure and not all the other 15 problems when they came into their PCP appointment. And so that, the patient feeling heard, sometimes they connect a little bit better, and then maybe we are able to make quicker progress in our more intensive program, and being able to get more visits in between their provider visit. And something that I didn't mention is that we have a collaborative care agreement. So myself or the pharmacist in the program can make some med changes when they come into the BP at Home Plus program. But then on the flip side, we have some patients that are like, I want to come see you, I want the blood pressure cuff, and I want to talk to you, but we are not making any changes until I go back and see my provider. And so making sure those lines of communication are open, and helping the patients get back and scheduled with their PCPs has been huge for us in our program, and having access to the EHR and scheduling in the same system is important, because there are patients that go way too long without seeing their PCPs, and we're able to do that immediately to get those appointments scheduled. And I think that helps a lot with keeping the patients engaged and in the system with both the program and with their PCP.
And this is kind of related. I got a question in via text from an attendee who knows my cell phone number. Jenny, this is kind of related to that provider and patient relationship that we kind of have danced around a little bit. But can you share how you get provider buy-in for SMBP?
Well, it really wasn't hard in our group because I'm dealing with 13 providers and I see them every day. Because we have some satellite clinics, but we all know each other. And so I just harass them first off, but they just don't tell me no, because the health work side, employers are engaging us specifically for their population. And so the more we engage their employees and spouses and dependents, the better our marks, right? And so those providers want to do as much as possible to engage their employees and their patients like that. On the family practice side, our owner is in charge of that. And he also has an ACO group of 12 physicians, other family physicians outside of HealthWorks, who also want to engage in that. And so it feeds off each other because it works. I just don't have any issues with them. And if I do, I just take them a cup of coffee and go, it's going to be great. Let's get this done. But it's a little different because I don't have thousands of providers that I can't imagine how everybody else does that, because that's very hard. But for me, I've got 13 that I harass daily.
Yeah. I was just going to add, that, I mean, I think, for our programs, we have a group of providers who are kind of early adopters, and they jump in and are a majority of our referrals. And then we have some who probably haven't used either program yet, but it's just a continuous process. And sometimes even having one patient and seeing the impact that it can make, can kind of get through all the noise, because providers have so much going on. Even just a couple of weeks ago, I had a provider call me and say, my patient told me that they have been taking their blood pressure at home and that I should be able to see their readings. And so I printed it out and brought it down to him. And now he has been referring patients to get blood pressure cuffs because it just hadn't cut through the noise yet. But having that patient mention it to him and being able to see the graph of the home readings and how that can impact his care, that made an impact for him. Seeing results.
That is fantastic to hear. I promised I had a question about success stories. So behind data, we talked about some of the data impact of the implementation of these processes, but behind data is stories of real people and real patients. And I just want to hear, do any of you have any success stories to share? Maybe I'll start with REC. You've worked with many practices, so you probably have several success stories that you've heard, that you've been told. Has any one or two in particular stood out to you?
One that stands out, that's the first thing I think of is, the SMBP providers go above and beyond to help the patients. And this particular example was a patient in Eastern Kentucky who lived in a holler, who had a access road that had to come out that had a bridge at the end of the access road to get out to the main road to then go into town. Well, and all this going on during a pandemic, as well. The flooding hit that area, and that patient's little bridge was washed out. So their only access to the main road was now gone. Well, the Breathitt County Health Department, their SMBP provider, said, it's no problem, I'll come out. They came out, brought their lawn chairs. The gentleman walked from his home crossed the path, where the bridge used to be that didn't have any water anymore, but it was safe for them to cross, and sat there in their lawn chairs, socially distant. And they were able to give them the blood pressure cuff, talk to them about their first, give them their first educational encounter, and just going that extra step. And they even went above and beyond after that to write the county about trying to get the bridge, fixed for that patient, And so that patient, they're going to remember that provider forever. They went above and beyond to try to help them. And, after that, the patient was able to, maybe the brother would bring them in or stuff like that. Or oftentimes another example during the pandemic was they might drop off a blood pressure cuff for someone's porch and stand out and talk to them. And then they would do the next few visits by phone and the final visit in person, but socially distant. So I can't say enough about the providers of SMBP that go above and beyond for their patients. That's just one example.
That's fantastic. And I think the rest of you have at some point mentioned some success story. Do any of you mind sharing any of those?
Go ahead, Ms. Kristen, sorry.
Oh, I was just, so Cassie and I, we have a participant who represents I think the ideal of how we hope our two programs work together, which is that he saw his provider very out of control last July. And he was one of the first patients to get a blood pressure cuff in the BP at Home program. And I think he was not convinced that his readings were high. He just thought they were high at the doctor. But he was using the app, and we immediately started to see these very high readings come in, which looked like they have a little ambulance next to them in our dashboard. And he was like our first ambulance. So it's very dramatic for us. But so because of that, he, I think, became more convinced that his blood pressure actually was high. We worked with him several times over the phone on his technique for taking his blood pressure, because it did take that to convince him that these were real readings. We were able to use those readings to get him in with urgent care and with his provider, and he continued to send in high readings on the app. And so then we were able to get him into the BP at Home Plus program to come in and talk to us specifically about his blood pressure, go over his medicines really carefully, and get the perspective of the team on what may be causing his persistent high blood pressure. And he still follows with us just to ensure that it stays in control, but he is now in control. It took several months. It took convincing him. It took having him follow with the PCP. It took having him follow with us, but really the home cuff and the SMBP and all of those players were needed to make it happen.
Jenny, I think you had unmuted as well. Do you have a success story to share?
I think probably, well, two stand out, but one for sure. One of the local sheriff's departments, they're very, I'm fine, we're all fine, I'll take care of you, don't bother me. And we had one gentleman that during COVID, when we set up a community COVID testing center for about 3 months. He was one of the ones that sat out there with us because we really weren't for sure how the public was going to respond at the time when it first started. And so he kept having headaches. And so we put a blood pressure cuff on him and educated him. And then over the next year and a half, he started convincing a lot of the officers to reach out to us, or he would call me, because I always tell him, do not take the blood pressure of someone else on your cuff, because if it's extremely higher or lower, I'm calling you to make sure you're okay. And he would call me and say, I'm fixing to take so-and-so's blood pressure. And he would do it. And he helped refer others who probably would not have come to us in the past, to the point that we've met with cruisers in places like the Walmart parking lot and have a training session on the hood of their vehicle. And that to me is, I don't know how you measure that success when you're trying to get data, but the ripple effect of this program for us anyway has been amazing. Just like Mary and Kristen are talking about, it makes people aware, and they realize that it's not just this number out there that doesn't mean anything. And it really is a wonderful program to get that ripple effect and make a change.
Fantastic. Allison, do you have any success stories to share?
I'm going to agree with Kristen. There's been quite a few that are like, oh, my blood pressure's high every time I come in the office, but it's fine at home, you know. And then once we referred and they actually see, I do believe that has really helped decrease the risk of stroke, heart attack. I mean, it's amazing. And then there's others that are making smarter decisions because they're able to monitor their blood pressure at home. They have their graph of, you know, red, yellow, green, good, caution, bad. And they've kind of been able to identify like the foods higher in sodium that they didn't know could raise their blood pressure, and they're making smarter choices. Some are. It's kind of helped them. Just the education part of it has been unreal about that too. But then also just decreasing that risk by the ones that thought they were okay is amazing. That's probably the most success I've seen.
So Allison, I'm going to stick with you for just a second. You know, the self-monitoring is, of course, the critical component of this program. And you've mentioned a couple of times, our panelists have mentioned that, you know, the numbers being generated at home are in some ways a lot more accurate just because they're at that resting, relaxed state. So the data that is generated from these patients, are your organizations integrating patient-generated data from the SMBP program into your EHR? And if so, what does that look like currently? And what was that implementation process like?
Like in regard to how
is that being integrated into the patient's chart? What does that look like in practice, so that that information is being as useful as possible?
On my end, it's a little bit different, you know what I mean? Because I don't like run the reports and everything. But for me, like, because we have several providers here, and I'm able to look in the chart and see like what they've monitored at home. You know, we don't use that blood pressure officially that they're doing at home. You know, we don't utilize that, but we can use it as a reference in regard to, okay, you know, we know this blood pressure is right because it's been verified by this nurse from the health department. But like I said, we don't actually like put it in. The blood pressure when they come in the office is what it is, but I can use their home one as a reference. Is that what you mean?
Yeah, essentially how you're using those patient reported outcomes.
Basically a reference, basically, you know what I mean? It's not like plugged in as an official blood pressure during official office visit, but better able to adjust their medicines for me.
And I'll turn next to our friends at Family Health Centers, because I think you guys gave me some more slides about some of that data and what it looks like to you and how you're utilizing it. And I'm going to pull those up and tell me if this isn't the right one, or if you want me to go forward or backwards in those slides.
So that's an example of what the dashboard looks like. And so you can see different colors and types of alerts for patients based on the reading that's coming in. So that's what we're reviewing when the patient sends in a reading electronically. And we are, it is similar to Allison, we are not able to put that into the patient vital sign section of the EHR as we would if they were seeing their provider, but we scan it in as an image that can be used as a reference. The standards for being able to put home readings into the EHR officially are very high, and so we aren't able to meet those with, you know, the way that our patients can realistically take their blood pressure at home. For the Blood Pressure at Home Plus program, where we are seeing the patient and on site or observing them in a telehealth visit to use their home cuff to take a reading, we do put it into the vitals section of the EHR. But I believe that when the UDS measure is pulled, it doesn't pull those numbers from those visits because it only pulls from a medical visit. And so they're in there for the provider to reference in an easier way, because it's right where they would be looking at all of their other past blood pressures versus in the imaging tab of the EHR. But as far as data, unless they come in and see their PCP again and have their blood pressure measured at a medical visit, the reading that we get, I'm almost certain, is not pulled as their most recent blood pressure reading. So if we see them in control, but they don't come back and see their provider before the end of the year and also show an in control reading, then they still may show up as out of control in terms of our UDS numbers.
Thanks for that insight. And I have had so much fun talking with you guys that we are out of time. And I had still a few more questions I know that I wanted to get to. But as one of our previous board members here at the KHC used to say, always leave them wanting more. And I think we're definitely doing that here. We do have one question in the Q&A box that I think, Mary, if might be best for you if you don't mind taking a look at that and maybe answer that via typing. But we're going to go ahead and move on with our program at this point. But if attendees have been listening to some of the questions, some of the comments that they've been hearing, definitely continue to utilize that Q&A. And I ask that our panelists take a look at that and see if there are any questions, any follow-up questions that they can continue to answer as we finish out the morning. So thank you to our panelists, Michelle, Dr. Hobbs, Mary, Allison, Jenny, and Kristen for the insight that they've shown. I've learned so much in our conversations the last couple of weeks from you guys. But we are going to turn our attention now. We've gotten a ton of great information today, but we don't want to just leave it at just that, just have great information and discussion and leave it there. So joining us for our final presentation is Karen Cinnamond for the Kentucky Heart Disease and Stroke Prevention Program. Karen specializes in developing and integrating data collection, management, and reporting systems with program planning and evaluation to assist programs to make data-driven decisions that improve program implementation and impact. Welcome, Karen. I see you were able to get your video working. I'm really excited about that. And I think I'm going to go ahead and turn over control to you at this point, if you want to advance your own slides.
Thank you. Yes, technology's working today. I am not seeing my slides. You need to share. There we go. Perfect. Okay, so what I'm going to talk about is next steps. You've learned a lot about how the EHR and health information technology can help with referral to CARES MVP as a really important management tool to improve uncontrolled blood pressure or keep people in control. And the first thing you want to do is you want to contact Natalie, and she will give you a little bit more information. And if it is something that your organization is interested in exploring, pretty much we come together as a team, and our team uses an implementation science framework, which, if you're not familiar with, is really about translating clinical research into practice. And we do stage-based, and so we help you explore the EHR and CARES MVP relationship. Then we help you get set up to install the program, and then we continue to support you in implementation. And I'm going to break those down quickly so you have a little bit of an idea of what each of those stages mean. So when we're in exploration, basically you've brought together who in your organization needs to be part of the process. And we talk about what CARES MVP and the EHR or health information technology would look like for your organization. And then we have a discussion about areas where infrastructure and capacity might be needed, or where you have some areas we can support and provide resources. For example, our partnerships with UK Rec, they do a lot of the data resources, making sure you can pull the data. Other sources is, are you going to have an internal program, or is there an external health department that you can refer to, or a community-based program? So we kind of talk about and explore what is the best fit. I've got a delay. There we go. And then when we get to the installation, we kind of talk about the workflow and how it's all going to look in your organization. And then the Department for Public Health comes and provides the CARE SMBP training for however that looks like. So in a moment, I'll show you some slides about a FQHC to community partner, and then an internal program where the SMBP is provided by other team members. In the initial implementation, we use data as the team meetings to help troubleshoot, shoot, and problem solve. We use data to track fidelity and stabilize implementation. As Natalie spoke about, we really approach this from an evidence-based perspective. And so implementation science and using this framework allows us to do that and to build the processes for communication and data-driven decision-making that needs to happen in order to successfully implement the program. And there's always the ongoing identification in order to improve program success and infrastructure. And when you get to full implementation, we do use PDSA cycles, which you heard the UK REC team talk about a little bit, and just test different enhancements. How can we make it better? One of the things that are on our end, if the team is using REDCap, we use the reports that are generated to look at implementation fidelity and how we can help programs make sure that they're getting the blood pressure readings in the way that they should, or the education is occurring as it's outlined in the program. And then we also begin to assess outcomes and continue to monitor the fidelity to the program like I just described. And we're always looking for ways to help produce more efficient and effective infrastructure to support those outcomes. The reason that I put the assess outcomes in red is I do have some that we turned into the CDC at the end of year 3 that we are very proud of our partners for achieving these. And I wanted to share kind of all this work, where it can get you to. So comparing a FQHC in rural Eastern Kentucky, where the provider refers to a community health department, their NQF 18 was 67.4%. And then for those who participated in CARE SMBP, it went up to 76.4%. And in another one in a large urban area, which has the internal team-based care clinic, it was 57.3% for the entire FQHC, but it was 65.3% for the people participating in CARE SMBP. And then, excuse me. And then here you can see where they had a mean change in the patient systolic and diastolic. And if you remember back to Natalie's slide, just even a 5-point change was amazing. So we're seeing in the rural Eastern Kentucky one, 17.5% change, and almost 13 in our large urban partner. So those are really significant outcomes that you would be able to initiate through your EHR process of identifying and referring, and then closing the loop and getting the patient logs and improving patient outcomes. And then you can actually see the data as a practice to help you make even more data-driven decisions to make it even more efficient, or include more patients. And we continue to provide the support to help look at the patient level and the provider level. So are there any questions or comments about we've given you from the beginning to the end? And if you're interested in participating in it, and we've given you the next steps. So are there any final comments or questions that you would like to ask before Stephanie closes us out.
I don't see any questions in the chat. I'll actually turn it over to Jenny.
Yes. Thank you, everyone. What an amazing morning that we've had, and coming in from the employer's perspective, having spent several years running health plans and both fully insured and self-insured, it is very refreshing to hear the providers talk about CARE SMBP and tying it into quality, looking at the data, helping people know what they need to be doing from that provider perspective, but then from the patient perspective. So I think, I just definitely want to thank everyone on the panel. Would like to thank DPH for the information and the partnership to pull this very informative presentation together, because I think there are so many areas that whether you're a provider or some of you may be patients and you may be thinking about it from the perspective of, what about my blood pressure? One of the things that really stands out to me in this morning's presentation is how everyone is meeting the patients where they are. I mentioned coming from that employer perspective, we know we have members when you have health plans, people who struggle to read, people who, as was mentioned with some of the examples, they live in areas that make it so challenging. And this SMBP program really helps people understand the issues of hypertension and how it's impacting their lives. So I can't say thank you enough to what's happening, to what we heard this morning and what's happening in the community of healthcare with the guide from DPH and the different providers who were here with us today, sharing the program of CARE SMBP and other ways to help people get their hypertension in control. As we wrap up this morning, I want to make sure I highlight a couple of programs that are coming up. You heard community health workers mentioned several times in today's presentation. They really are amazing partners in both the healthcare communities, but also employers having access to these folks. And what we're going to be doing in September is really highlighting how we can remove barriers to care with our community health workers. They really are people who can help meet our patients, our healthcare insurance, if you're an employer, your members, where you meet them where they are and help make sure that they get the health care that they need. That is on September the 13th at 8 a.m. Another community forum. You can go to khcollaborative.org and learn more about that and go ahead and get registered. And then also coming up this month, we're continuing our healthcare equity series with an equitable healthcare event focused on the LGBTQ plus population. We're very excited about this particular event. Registration is open. It's June 21st from 4:30 to 6 p.m. We have several people coming in for this event. GE Appliance, their Pride coordinator, is coming in. This is Pride Month, and we're very happy to be able to offer this particular series webinar during Pride Month. So we have someone from the GE Appliances from that employer perspective. And then we have a couple of members or community leaders in the space of LGBTQ care. And we will have those folks coming in too. So please reach out and register for that. And I see that Natalie has put the registration links in the chat box to make it easy for everyone. So unless we have further questions, it looks like we're going to give you maybe 5 minutes back of your time. And just as a reminder, the event is being recorded. So you'll be able to access these resources at this website also, which that information is in the chat box. Thank you, Natalie, for taking care of all that. And a special thank you for Stephanie for pulling all of this together and working so closely with Lana and her team to bring these excellent providers and speakers together to help us understand the importance of the CARE SMBP program. Thank you all very much. Have a great Tuesday.